There's another common reason patient tell that in the matra putta onnu kekala swelling innu irukana, the way they take also matters a lot. Okay, it is how it is should be taken, the absorption part, the right dose, everything matters a lot for a drug basically to respond. So that is also a key basically whenever we are prescribing an antibiotic. Okay.
Azithromycin is the most abused drug of the latest report.
Sorry sir.
Azithromycin
Appears to be
abused drug in India.
Abused drug in India.
Everybody goes to the pharmacy and takes azithromycin for cold. So they say it is not, as of now, it's not working.
Yeah, sir. That's why sir, what happened was on the particular time azithrol or azithromycin was not working at all. Appo what happened was our ENT people started shifted to levofloxacin. Levofloxacin once a day really did well for those patients who had all the URIs basically. Because as sir said, azithromycin left and right people are using. Once a day dosage, people prefer it very much, and it's all known factor that any respiratory tract, any throat pain that you have, you start with azithromycin. Any layman now does that. That's a major problem. So when do you now prescribe metronidazole? Now this is antibiotic, right? All these are spectrum, basically gram positive, gram negative, all bacteria within our mouth. Okay, but we have one more spectrum of bacteria which is anaerobes. Okay, anaerobic bacteria vada metronidazole basically targets. Okay, so metronidazole, metrogil, when do we prescribe?
First, when there is a
pus, yeah. So when there is an abscess could be a periapical abscess, could be a dental abscess, or space infection and dental abscess. Multiple space means it's a cellulitis, or any facial infection basically leading to trismus of the mouth, or submuscular or infratemporal or pterygomandibular space. So all these space infections generally we give metronidazole. Okay, so that is one indication when we give metro. The second one is you do an endodontic therapy. You keep doing. Okay, the patient is under your therapy. Suddenly there's a flare-up. There's a swelling over there, despite he being on endodontic therapy. Then again you start the patient on metronidazole. Works well. Generally, what they say endodontists is dentinal tubules are resistant to any antibiotic you give. Endodontic people, that is root canal, but nobody gives antibiotic. Generally, we don't give antibiotic at all. Okay, because once we do the procedure, antibiotic kudukadilla, analgesic kudukadilla, patient is fine only. Okay, the theory behind what they say is systemic antibiotic doesn't reach the dental tubules at all. So you don't require hypo, which if you clean, no, that is enough. That is the best disinfectant or the best sterilized procedure that you're going to give. So generally we don't give, but if there's a flare-up during the procedure, okay, it's a reinfection. If there is a swelling, then again we give. Transalveolar is better. You are exposing the bone. Bone is exposed to the oral cavity. Oral cavity exposed on only, you get all the normal commensals now attacking your bone. So when you do a when you do an intraction procedure, better to start a metronidazole. Despite you will be giving the best of the best sterilized protocol, but still people recommend that when there is an opening, when there is a bone is open, probably there is a chance of infection and metronidazole is given. Any aggressive periodontitis, again it's given. Dose. What is the dose? 400 mg. Thrice. Many of them don't give thrice. Many of them give only twice daily. Thinking that metallic taste varum, patient ke taste maridum, nausea, and the many symptoms irukum, patient are not very comfortable. No, the dosage is basically 400 thrice daily. You have to give the dose. Without giving the dose, there's no chance that the infection will reduce. Okay, so it is thrice daily. And
now we have Lagin ER 2 times 600 mg.
600 mg. Yes, I have just come. We have tinidazole also. Tinidazole also is giving that 600 basically. And we have the Ciplox-TZ combination. Ciprofloxacin 500 mg, tinidazole in the 600 mg. Combination drug also is given basically. Okay, so this is 48 hours. Okay, basically sir, the dosage is 1200 per day. That's all. It's 600 twice or 400 thrice. We are not bothered. And yeah, any alcohol intake, do definitely ask. And 48 hours, at least 48 hours after the last dose, you should not. They can develop some reaction. Okay, so this is your metronidazole. Okay, plain met you give along with any antibiotic that you are combining with, it's fine. Amox 500 with metronidazole 400, it goes on well. You want to combine. Patient is allergic to amox. Okay, combine it with ciprofloxacin. In the tinidazole is 600 mg combination, 500 mg. You have one Ciplox-TZ which is only ciprofloxacin is 250 and tinidazole is 300. It's half the dosage. Make sure that you are giving the proper dosage. Okay, so. Whenever I was searching only, I just found out that Ciplox-TZ combination is also there, okay, which is half the dosage basically. Okay, so Cifran CT or Ciplox-TZ is okay, where you combine 600 mg of tinidazole and your ciprofloxacin also. Okay, This also has an excellent group. So another twice daily you can give. So Ploxone twice, 600 mg trinazole twice. So it's okay to combine these two drugs together because one is thrice, one is twice are being there. Okay, this is twice daily. Okay, so this is basically the combination that we are doing. Okay. So next is idella antibiotic which we usually take. Okay, the antibiotic we can also prepare our own mouthwash also. Okay, so when do you think that we can use this? 250 milligram or capsule or a tablet of tetracycline, 100 ml of water, you ask them to mix. Okay, 1 minute you ask them to keep it in the mouth and then spit it out. It will be severely bitter. You have to tell that. Okay, maybe they can take a bit of honey or something after that. Okay, but works well, especially in shrinking the mouthwash. So, என்ன shrink பண்ணு? Ulcer. ஏதாவது ulcer இருந்துச்சுனா வாயில basically we have our oral commensals, so that will see the why this after ulcer stays there for a week is because though the ulcer is there, it's all the secondary bacterial infection which acts upon this, makes it a little more bigger, wider, adukapram it starts shrinking. So you started immediately by giving a tetracycline mouthwash. Tomorrow add on that, you just give it to them. This might also work out well. Okay, so they can just take it twice daily. 1 minute they have to keep it in the mouth and then spit it out. So that will drastically shrink your ulcer, or at least prevent your ulcer from becoming bigger also. Okay, after ulcer is one major problem because people find it very, very difficult to eat in the 1 week, especially if they have some recurrent episodes. Okay, so in this mouthwash is our own made mouthwash. Okay, which is quite useful. This tetracycline mouthwash. Okay, so during endodontic procedure, so we have already seen this. So do we give generally? How many of them give regularly an antibiotic for an RCT? Any RCT?
Non-vital we give.
Non-vital give regularly. So even pain, no pain, you definitely give antibiotic. Okay, non-vital. Anybody else? You give non-vital you give. Okay. I don't give for non-vital teeth. Okay, I don't give generally, even if it's pain, if it's tendon percussion, even if I find a periapical abscess in the radiograph also, generally I don't give. Me and my endodontist team doesn't give. Basically, it has worked out well only till now, thankfully. Routine RCT, that's what I generally recommend, but with other inputs also, you can again discreet whether you want to give an antibiotic or not. But if there is an abscess, okay, clinically if there is an abscess, a flare-up in between your endodontic treatment, okay, and you do the re-RCT, okay, and then you've kept a medication, and then again there's a flare-up of that. All this flare-up basically during the mid-treatment, you can definitely add on an antibiotic, okay. And what antibiotic they generally prefer this time is?
Mainly when you are doing a root canal, chances of your instrument going periodically is high. So chances of the infection reaching systematically is high. So better to always give an antibiotic to cover your body against the infection into the system.
So this is all one group of theory. But I'm here, okay, where we don't give antibiotic also, and it works well as well. What we basically feel is all these instruments are all sterilized and then we do it, but still as if there is a chance for infection, you think that you want a couple of antibiotics.
Claim that the periapical area can take up the bacterial load and heal. If you have the bacteria within the tooth, there is always a problem. Even if little bit of excess being pushed through the periapical region, it gets better tolerated by the body. So that's why they say like, now endodontists are very much against antibiotics. Most of the endodontists are avoiding antibiotics, and maybe symptomatically we can give a painkiller analgesics for a day or two, or otherwise they are not giving antibiotics.
Antibiotics, and we don't give even analgesics also unless there's a pain only we give, otherwise we don't give. But when such a flare-up comes, what we prefer generally is not a routine antibiotic. What we advise is only metronidazole. Okay, because again this is a theory, again what the endodontist, where their clinical practice guidelines tells that whatever systemically we give doesn't reach the tubules at all, and there is no point in giving an antibiotic for endodontically treated tooth. Flare-ups is because of abscess, because of anaerobes. So in that case, add on with a metronidazole, that will take care. So that's it. So don't load the patient with an antibiotic if you think it's unnecessary. Again, it's a discrete decision of that particular clinician. But what I or we generally recommend is go for a metronidazole. Antibiotics during extraction is mandatory. All time we give? No. Sir doesn't give antibiotic all the time. Sorry?
It's traumatic, yes.
Only traumatic. Okay. Yes, sir. Anybody, any other thought? Routinely you give antibiotic, ma'am, for all the patients? For all patients? Continue the antibiotic. Okay, so this theory is that generally antibiotics is preferred because again what claim the oral and max surgeons tell is, though we do sterile procedure extraction, there is a possibility of contamination. And when the tooth is out and the bone is exposed to the oral cavity, there is a chance for infection. So generally an amoxicillin is a preferred group of drug post extraction. So that is one. If you are going to take a tooth which is periodontally compromised, which is a very weak tooth, periodontally compromised, abscess tooth, again probably doxycycline would be a better choice. And whenever you are going to deal with any diabetic patients, any transalveolar extractions, mandatory that you give an antibiotic, because you will have an exposure to the bone from the commensals within the oral cavity, which is going to flare up the infection. So it's better that we give antibiotics. Most of the times we do give antibiotics. Okay, so that's how it basically goes on. And unless you are allergic to amoxicillin, all the other group of drugs comes into place. So that's basically the procedures how it goes. Okay, so this is the whole group of majorly antibiotics. Have we left anything? Anybody wants to add on any other antibiotic? Unlike other specialties, no, for us we all revolve around amox. Okay, so amox. Next options we need to keep. Okay, 90 to 95% we will gel with amox itself. Amox has become a part and parcel of the dentist family. Okay, but in case there's a situation where you cannot give an amox, okay, and you prefer some other antibiotic, make sure that you know the dosages and up to what maximum dose that you can go for. So that if you have in your mind, at the time you need not search or anything, or then you can give you can have your list of plan A, plan B, plan C, plan D, and then you can work out accordingly. Okay. So just to have a break, drugs, doses, it will be more. So we'll have a clinical scenario. We'll discuss this. Go back to again our analysis. Okay. In the patient with breast cancer. Now we have a lot of cases of breast cancer coming up. Okay. And these two patients have all come to our clinic. We'll first discuss the first patient. First patient, breast cancer, stage 3. Okay, stage 3. Yeah. So she underwent surgery. She underwent radiation therapy. She underwent chemotherapy also. All over 6 months back. Okay. Now she has come to you for a bad tooth, severe toothache. She has come to you for extraction. Remember, she has undergone even radiation therapy also. Now, what will you do? This side first. Extraction or the extraction RCT. Extraction will you do? Sir, this side.
First get the permission from the oncologist that we can extract.
Okay, sir wants to get permission from the oncologist. Okay. Anything else? Anybody from?
Definitely go for a
So
dry
oncologist.
socket. Definitely go for a dry socket.
It will go for a dry socket. Okay.
So you have to
Because radiation therapy.
Radiation is nowhere related to oral
But
cavity.
still, oral radiation, there are chances that chemotherapy is immunity. So all these things you have to take in factor.
Okay, so this is it's okay. So this side, sir. So sir has told oncologist referral, dry socket more prone for So yes, anything check the CBC. Everything. Okay. So the first thing is that this is breast cancer radiation. Okay, our field is only this much. Namma field head and neck radiation kudutha mattunda there's a possibility of an ORN, osteoradionecrosis. Now this is only breast cancer. So radiation, oral cavity, there is no relation at all. You can boldly do without the oncologist's consent, number one. Number two, surgery, that's no problem. Surgery panni mudichachu. Okay. The second part is chemo. Chemo panirukanga. So can we do extraction?
Check the blood.
Sorry?
Blood.
Anybody else? Any other thoughts?
CBC
6 months over. 6 months over. Usual as it will regain. And the chemotherapy active the 3 weeks bone marrow suppression will be there. All the counts will be less. 6 months so most likely the counts will be normal. But if you want to make sure, doing a CBC is absolutely not contraindicated. You can always do a complete blood count, check whether the count is normal. So radiation there is absolutely no contraindication. You need not go to an oncologist for that case. Okay. Next patient. The 50-year-old, the breast cancer, but she had surgery, chemotherapy. Here no radiation therapy. Stage 4. Now she has a recent history of bone metastasis. That's on the sheet and the document. Okay. Now again plan for extraction.
Some other doctor refer to.
Yes. So in the patient treat the entire family will become your patients. Actually, yeah.
And the whole pet and the whole family is worse.
It won't, sir. If you are rationally and we have an approach towards it, sir, definitely will not happen at all. Number one. Number two, sir, நமக்கு வரதே ரெண்டு பேஷண்ட் தான் வெச்சுக்கோங்க சார். அந்த பேஷண்ட் நம்ம என்ன சார் பண்ணுவோம்? என்ன மாதிரி கிளினிக்கெல்லாம் அப்படிதான் சார். உங்களை மாதிரி கிளினிக் தான் 20 பேஷண்ட். ஸோ அது மாதிரி வந்து ஒரு பேஷண்டே நான் அனுப்பிச்சிட்டேன்னா அவங்க எதுவுமே பார்க்க மாட்டாங்க. சுற்றி வேற 10 கிளினிக் வேற டயக்னலி ஆப்போசிட் as one clinic which has started. அந்த மாதிரி நிலைமையில இருக்கேன் சார்.
All silent is happened. Diagonally opposite service போய் மாடியில இருக்காங்க.
So two options in there. The bone metastasis is a crux over here. So in the bone metastasis now what supplements will they give? Any idea? Bone mets la irukumbodhu what happens is two things can happen. Illa sir, they put them on bisphosphonates. Bisphosphonates is the one which can cause osteonecrosis. Okay, so adu radiation nala vara necrosis, idu drug nala vara necrosis of the jaw. Okay, so what happens is ipo recent history of bone metastasis endra mattum da irukku. Patient started no start பண்ணலையா தெரியல. Two things can happen. Patient start பண்ண போறோம் bisphosphonates னு சொல்லிட்டு they'll send the patient to you. நீங்க கம்ப்ளீட்டா ஸ்கிரீன் பண்ணி எல்லா filling whatever restoration extraction எல்லாம் பண்ணி கொடுத்துட்டீங்கன்னா they'll start just like pre-RT prophylaxis, pre-bisphosphonate therapy மாதிரி நம்ம உட்கார்ந்து எல்லாம் ஃபுல்லா முடிச்சு கொடுத்துட்டு வரா they will start with the bisphosphonates. That's not a problem. We are safe because அவங்க நமக்காக தான் அனுப்பிச்சிருக்காங்க. We'll do everything. But if the patient is on bisphosphonates, you have to definitely get the drug history, zoledronic acid, and the மாதிரி ஏதாவது ஒரு drug name இருக்கும். And the drug palmidronic acid and the மாதிரி. So if the patient is already started on bisphosphonates, please don't do extraction. You are going to end up with osteonecrosis. Okay? And again, நீங்க refer பண்ணணுமா oncologist கிட்ட? Yes, it's better that you refer this patient to oncologist because the oncologist is the one who started the bisphosphonates. So better get a consent before that. But there's another drug we can do also. That I'll tell you later. So இதுதான் வந்து இந்த ரெண்டு scenario-ஓட basic thing. Okay? So in general வந்து remember that breast cancers தான் நம்ம breast cancer இல்ல anything below your breast basically any cancers nowadays lots of cancer patients are there. colon எக்கச்சக்கமா வருது, prostate வருது, breast வருது, cervix வருது. Okay, so don't worry about the radiation part. Radiation பிரச்சனையே இல்லை. கீமோல மட்டும் அப்போ ஆக்டிவா இருக்காங்களா இல்லை முடிச்சிட்டாங்களான்னு பாருங்க. ஆக்டிவா இருந்தாங்கன்னா CBC mandatory and get a permission from the medical oncologist here. Okay, if they are not on chemotherapy already completed, just take a CBC, all the parameters are normal, go ahead with the extraction, no issues at all. This is for anything below the neck level that I'm telling. Okay, இதே சப்போஸ் இந்த மாதிரி bone metastasis இப்போ எந்த கேஸுமே கொஞ்ச நாள் கழிச்சு மெட்ஸ்ல வருது and bone metsக்கு mainly they give bisphosphonates, they give it for Page's disease, they give for osteoporosis. So female patients more than 50 osteoporosis bisphosphonates கொடுக்க சான்ஸ் இருக்கு. இந்த மூணு கண்டிஷன்ல bisphosphonates உங்களுக்கு ஒரு slightest doubt இருந்ததுன்னா don't attempt extraction immediately, you have to wait and do. Okay, so that alone you just remember. So before we start with that, அது என்ன பண்ணனும் சொல்றதுக்கு முன்னாடி என்னென்ன கேன்சர்க்கெல்லாம் we have to get as a whole permission from the radiation oncologist. Because இதெல்லாமே radiation zone. என்னென்ன கேன்சர்? oral cancer first one, right? வேற என்னென்ன இங்க வரலாம்? Thyroid, yeah. Thyroid I have not included. It's thyroid, sir. Yes, sir. But thyroid என்னன்னா mostly they give ablation here. Radiation therapy கொடுக்காம ஒரு gamma radiation அங்கேயே கொடுப்பாங்க. So அதனால generally it is localized only, but we can consider thyroid also. Anything? Nasopharyngeal carcinoma, very good. Then
brain tumor.
Brain tumor, yeah. Okay, yeah. Brain tumor. Anything else? Salivary gland, good. அதுவும் நான் include பண்ணல. Okay, OCC, oral squamous cell carcinoma. Okay, nasopharyngeal. Then we have lymphomas. Lymphoma is quite common, okay, nowadays, okay. And in fact, my orthodontist himself had a lymphoma. Then we had to treat him and he's now fine. He's doing very well. In fact, he ran a marathon. 6 months back, he was diagnosed with lymphoma. He was treated by my husband. Adukapparama, he is now doing and he finished half marathon 2 months back, full marathon ipo mudichirukkaru. So, lymphoma. Then you have your orbital cancer, okay. Oropharyngeal. That is your throat, larynx, pharynx, tonsil, எதுனாலுமே and your whole body radiation, including your brain tumor as well. So in the case la எது வந்தாலுமே radiation கொடுத்திருக்காங்கன்னா better that you get a consent from your radiation oncologist. It's always mandatory that you get. Okay, so whomever cancer institute இல்லை வேற எந்த radiation oncologist better to get an opinion from them. Okay, for clinical practice, remember in எல்லா patients with the cancer, chemo, இந்த patient எல்லாமே chemo கொடுத்த எல்லா patientமே mandatory ஒரு CBC check பண்ணிடுங்க. It's better. We are on a safer side before we are going to attempt an extraction. Then எங்கெல்லாம் ரேடியேஷன் இப்போ பார்த்தோம் இல்லையா, ஆர்பிட், நேசல் கேவிட்டி, ஓரல் கேவிட்டி, ஓரோஃபெரிஞ்சல், இது எல்லாமே ரேடியேஷன் ஆன்காலஜிஸ்டோட கன்சர்ன் வாங்கிடுங்க, டாக்குமெண்ட் பண்ணிக்கோங்க, யூ ஆர் வெரி வெரி சேஃப். ஓகே, implants டெஃபினட்டாக அவாய்ட் பண்ணுங்க. Please don't give implants at all. It is definitely going to fail. Bone will get necrosed. அதனால implants போடவே போடாதீங்க. Any other option that you can give for the patient because unfortunately the patients க்கு multiple extractions நடந்திருக்கும். So they will be dentures also. Think through something else but not implants. Okay. Next, this is an important drug which you have to know, which is Trental. Pentoxifilin or a drug, it's a vasodilator. 400 mg twice a day. Routine we practice in Ramchandra. Patient radiation கொடுத்துட்டு, it could be 6 months. It could be 2 years. 10 years முன்னாடி radiation கொடுத்தாங்க. இப்போ என்னங்க அதுக்கு பல்லுன்னு என்ன டைம்ல கொடுத்தாலுமே radiation. Make sure that you give this pentoxifilin at least 2 weeks before the procedure. 2 to 4 weeks ரொம்ப ideal. கொடுத்துட்டு then you do the extraction. Definitely the chances for osteoradionecrosis is reduced by 50 to 75%. It is called as a Pento protocol. So it is protocol now. And centers, big centers, oncology centers do practice this. And அது மட்டும் இல்ல, 6 to 8 weeks post extraction you have to continue. It is just not that you start off and leave it. 6 to 8 weeks you have to continue till it completely heals. Okay, so you make sure that it completely heals. And multiple extractions is na tak you just finish it off in one go and then you can any radiation in the zone எல்லாமே including your bisphosphonates because that's also osteonecrosis. For your osteoporosis, for your breast cancer. So எந்த பேஷண்ட்க்கு bisphosphonates கொடுத்தாலுமே கூட give Trental and then you start. இதுக்கு மேல osteonecrosis வர chances இருக்கு. You just can't prevent it. But what we are doing is giving the best shot as it doesn't occur. Okay, because already the patient is in so much of psychological trauma and underwent so much of trauma of treatment and come back to us. A jaw fracture trauma we should not give. So, and the patient cannot be living with pain also because the more the abscess is going to become bigger, chances of again getting necrosis is also going to be high. So, adanal we try to give a drug basically which vasodilates. Only thing that you have to be sure is suppose the allergy part irundichna in allergy indra the patients are on aspirin or propylate. Okay, because the chances for bleeding might be there because this the phenomenon itself is vasodilation and it increases the bleeding in that area. Appoda heal agadhukku it promotes. So already existing bleeding disorders, aspirin, clopidogrel, that use it with caution. Maybe you can reduce the dosage 200 twice daily also. But monitor the patient. Okay, platelet counts check பண்ணிடுங்க, bleeding time 49 check பண்ணிடுங்க, 1 week once check பண்ணிட்டு, then go ahead with the extraction and then continue for 6 to 8 weeks. Keep him on the follow-up. Okay, because this is worth. I know this doing an extraction is not going to yield you much of a money, but this patient is your patient because that care basically has to be given. The entire family becomes your patient. So that is the most important thing that you are doing. And conservative management for radiation use cases. Avoid extractions preferably. RCT engella panna mudiyumo try to do it. Even if it's a broken tooth, avoid extraction. Adukku RCT panni and palla abbe vichittingna kuda pall vali illama that's okay. So root canal is preferred. Don't go beyond apex. Be very very careful that you are not going beyond apex for a radiation therapy given patient. And wherever possible try to do RCT and preferably avoid extraction. Okay? So then I want to put clinical tips for your clinical practice because we are now going to see a lot of patients with cancer hereafter. Okay, so next generation is going to be a lot of cancer patients. So we should be knowing how to do it. And then suppose now ma'am was telling inaugural. Now we are the ones who diagnose many of the lesions. Okay, we will be the first person to diagnose cancer, but we might not be in a position to treat cancer basically. So on the time when we are not in a position, but that patient we are the one who has first identified. So make sure that you call the patient back. See that what is happening. Radiation therapy is started abina. Make sure that every week you see the patient. The moment he develops some mucositis, xerostomia, caries, give him the wholesome treatment, whatever is required. Fluoride application gel. Make sure that it doesn't progress because whatever patient we see, whatever we try to do, definitely radiation caries comes because of